Dr. Pratik, if he's available.
Sure, sir. I'll just give a call to sir.
Sir is here. Pratik sir is here already.
Okay.
Okay, great.
Good evening, sir.
Ma'am, we are live on YouTube now.
Yeah.
Purva, you can start now.
Yes. So, good evening, everyone. We are now in the almost 1.5 year of Nephrocon, and this month we will be discussing Banff ABMR clinical utility and decision making. We came up with this topic, and we are going to continue this topic for the next 3 consecutive webinars, because we think that there are some issues that we face when we apply Banff in our clinical practice. And that is why we have eminent speaker, Dr. Swarnalata ma'am from Hyderabad, and then followed by a panel discussion with Dr. Arvind sir, Dr. Pratik Das sir. With the panelists, we also have with us Dr. Shruti Tapyawala ma'am, Dr. Dhanashri Rahalkar, and Dr. Neeraja ma'am will be joining us shortly. Because I think apart from the tissue evidence and the clinical aspect, even the immunology aspect is as important to treat and take care of ABMR. So at present, as far as the clinical practice is concerned, when do we suspect ABMR is when there is a rising creatinine, or there will be some proteinuria, or the graph Doppler suggests some changes that are showing that the blood flow to the kidneys are compromised. And then, of course, when we go into the depths of it, we have immunological assays. But the most concrete evidence is through which we can treat ABMR is histology, which Dr. Swarnalata ma'am would be sharing with us now. So over to you, ma'am.
I can share, right?
Yes. Yes, stop.
Can you all see the slide?
Yes, ma'am.
Yes, ma'am.
Yeah, okay.
Yes, madam. Yes,
So, yeah, begin by wishing all of you a very happy Independence Day. And it is with great reverence that we remember our freedom fighters because of their sort of contribution. Today, we are able to enjoy the freedom of sitting in the comfort of our rooms and discussing this important topic. And a big thank you to Dr. Purva and the other organizers of this meeting also for this invitation. So I begin by discussing 2 very typical case scenarios. They are from our case files, the actual history. This was a young man, 4 days post-transplant, spousal donor. He had a history of an earlier cross-match positive for which he was treated with rituximab. And because the DSA was negative, they went ahead with the transplant. But 4 days post-transplant, this was the biopsy for graft dysfunction. And you can see that the tubules show a lot of injury, but it's not just that. The glomeruli also look abnormal. And when we go to a higher power, you can see that almost all the glomeruli, these are the various stains, have thrombi within. Very well brought out in the trichrome stain as this red material. These are the RBCs. The paler red granular material are the fibrin thrombi. Note that there's also some glomerulitis over here. And then we go back to the tubular compartment. There are these inflammatory cells sort of circling the tubules. And if you look very carefully, most of them are in the PTCs, in the peritubular capillaries. There are both lymphocytes and neutrophils. So this is peritubular capillaritis. And C4D was positive. So this was a classic active antibody-mediated rejection with microvascular inflammation and with TMA. These are the Banff scores. You can just remember them for the moment, and we will come back to it at the end of the talk. A second case scenario, 2 years post-transplant. There was a history of a biopsy-proven ABMR a year and a half earlier, and 6 months earlier, and she had had COVID. And during the COVID era, all of us know that rejections were precipitated by the infection. She had a rise in creatinine of 1.8, and this was a bad-looking biopsy. Lots of blue there, which are the inflammatory cells over there. Most of them are lymphocytes. There's also tubular atrophy with a lot of inflammation over there. Look more closely and you would find tubulitis. You can count like 5 lymphocytes within this tubule. So there is tubulitis for you. And the glomeruli are also bad. There is glomerulitis. You can see all these capillary lumina obliterated by swollen endothelial cells, lymphocytes, neutrophils, macrophages. There is glomerulitis. Is the basement membrane okay? Not really. For in the silver, you can appreciate maybe not so well at this resolution, but there was definitely some areas of duplication. So that was transplant glomerulopathy. And go back to the capillaries, and you can see that all these peritubular capillaries have lymphocytes within. These are the less inflamed areas where you look for the capillaritis. The artery included was quite normal, and the C4D was strongly positive in the peritubular capillary walls and along the GBM. So the diagnosis was again quite clear-cut. There was evidence of inflammation with tubulitis, which was a chronic active T-cell mediated rejection. And there was this microvascular inflammation with transplant glomerulopathy, which was a chronic active antibody mediated rejection. And these were the scores. Again, remember the scores. We are coming back to it at the end. So for the juniors in this audience, all of you know that 3 criteria need to be met. First, we need the histologic features, which we see under the microscope. We need to demonstrate that this injury that we see is due to an antibody interaction and the most against the endothelium. And the most robust marker for this is the C4D. So you need to demonstrate this. If C4D is negative, you can have this significant microvascular inflammation, or you can show gene transcripts. Now, this is a molecular study which has to be validated and which, to my knowledge, is not available in India at the moment. And the third evidence is you need to show that this antibody, this C4D activation, was due to antibodies against the graft. So the DSA, the donor-specific antibodies, which could be HLA or non-HLA. Now, fortunately for us, because C4D is such a sensitive and specific marker for antigen-antibody reactions, it is enough that we demonstrate C4D and the particular injury to call it an unequivocal ABMR, and that is what we do in our routine practice, as you have seen in the 2 cases. Now, what are the histologic features of active antibody? The acute injury are basically important is the microvascular inflammation in the endothelium of the capillaries, so glomerulitis, and in the endothelium of the peritubular capillaries, which is peritubular capillaritis. You can have large vessel endothelial injury as arteritis. Remember that it's seen both in TCMR, T-cell mediated, and in ABMR. And acute TMA, but this is not like specific. We know that TMA can occur due to other causes as well. Now, these are the acute thing. You can see the thrombi over here. You can even see these arterioles over here. Are these arterioles afferent or efferent? Like Dr. Girish Narayan would say, rota hai to ladka, roti hai to ladki. So really, we can't say as pathologists. If you see both, which is very unusual, then we could say. But otherwise, this is just fibrin thrombi in the arterioles. Okay. And remember that TMA can occur due to many causes like recurrent disease, CNI toxicity, any other cause for a de novo ABMR, de novo HUS. This is endothelial glomerulitis, which can be neutrophils or which can be lymphocytes. Typically, neutrophils, if you have a case of hyperacute rejection, And unfortunately, we still do see that in our country, not very often, but say once in a couple of months in our lab, we see a case of hyperacute. So there you get a lot of neutrophils, but usually in the other things, you usually see mostly lymphocytes, and actually there are a lot of macrophages also in this, which is why sometimes pathologists combine lymphocytes and macrophages into one term called lymphomononuclear. Okay. These are the capillaries. Again, in a very acute early stage, you might see a lot of neutrophils. What we usually see are these many lymphocytes. Now, these are lymphocytes in the vasa recta, in the medulla. Now, can they be taken into account? No, not according to Banff, because when you get tubular injury for any cause, then there is supposed to be a stagnation of these mononuclear cells in the vasa recta, and that is why we don't look at the medulla for peritubular capillaritis. Also, it is reported in literature that the HLA class 1 and class 2 expression in these vasa recta are much less, and the medulla actually gets only 20% of the output, the vascular flow. So that again is a reason why we don't see so much of vasa recta inflammation, and we also don't take it into account. End arteritis, it can be sometimes seen even in small vessels, and that's called arteriolitis. Not classified according to Banff, but very, very useful criteria for saying, yes, there is rejection. Remember, the unequivocal feature of rejection is this endarteritis. All the other changes can occur due to other causes. So this is again endarteritis, which is obliterating the lumen. And here there's transmural endarteritis with even fibrin. So this is B3 lesion. And these lesions, as I said, can occur both in TCMR and in ABMR. Interstitial hemorrhage. For those of you who are old-timers like I am, the first Banff in 91, their publication came out in 93, and they did mention interstitial hemorrhage as an indicator of rejection. We no more see that in the Banff papers, but in actual practice, it's very important. I find it very useful that when we find this interstitial hemorrhage, not on the sides of the core, but within the parenchyma proper, it's a very, very useful clue, and we start looking for other signs of rejection. Inflammation. Can it occur in ABMR? Usually when there's so much of inflammation in this, we think of a combined TCMR and ABMR, and we start looking for tubulitis. You can see this long tubule here, full of lymphocytes. When that combination occurs, we say it's usually combined, which is again not very uncommon. So this is lymphocytes, and some people would, like I said, may call it lymphomononuclear. These are neutrophils. Few neutrophils in the interstitium one does see in rejection, but when one sees abundant neutrophils and neutrophil cast, think of infection. Eosinophils, again, can be seen in rejection, and typically books mention eosinophil-rich rejections are usually bad, more resistant to treatment. One needs to think of a tubulointerstitial nephritis as well. Can one distinguish acute TIN from acute TCMR? Probably not. The histologic features overlap, and we believe that because the patient has been so intensively immunosuppressed, that drug-induced ATIN is uncommon, and any inflammation and tubulitis that we see, we ascribe it to rejection. Plasma cells, again, can be very prominent. We think of BKV, but again, it could just, if BKV is excluded, it's a plasma cell-rich rejection, again, resistant to treatment. C4D, we look for it in the peritubular capillaries as circumferential. It can be of varying intensity, smooth, linear, and it can also be, remember, along the GBM, and we find that again very useful, though it doesn't come in the grading criterion. Vasa recta, can you get C4D? Yes, you can. If you get medulla and you get C4D, definitely we would go ahead and say rejection is highly likely, even though we have not seen cortical tissue and other features of a rejection. So while PTC-itis is not useful in the vasa recta, definitely the C4D is very useful. So chronic active, what are the two changes? Just two changes are described. Transplant glomerulopathy and this peritubular basement membrane layering, which we need an EM. So these are the features of transplant glomerulopathy. You can see over here, very nice double contours because of basement membrane injury and remodeling. It's very much like what you see in a chronic TMA. And this is peritubular capillary dilatation with capillaritis. But under EM, you need to demonstrate this multilayering. These are two tubules full of mitochondria, and this is the peritubular capillary with multiple layers of basement membrane. So those, and that is C4D positive, similar to your active ABMR. We come to a third scenario. Again, an actual case history, 35-year-old lady, donor was a mother, haplomatch, 7 days post-transplant with a rise in creatinine. There was no induction because it was a haplomatch and she was triple drug immunosuppression. Pre-transplant DSA, CDC crossmatch were all negative, and the DSA at the time of biopsy was also negative. Repeated. And this is the core that we saw. There is some degree of inflammation happening here. Note that there's also a little hemorrhage, which made us think that we are dealing with rejection. And if you looked at the glomerulus, there was distinct glomerulitis. A glomerulus ought not to be so cellular, and you can see these lymphocytes and maybe occasional neutrophils, swelling of the endothelium, and you can also see these peritubular capillaries with lymphocytes within. So very typical. Note that there is edema but not much inflammation, and that is the peritubular capillaries outlined for you to appreciate the microvascular inflammation. C4D was negative and DSA we were told was negative. And so this is the entity that we diagnose here. This is microvascular inflammation, DSA negative, C4D negative. What about this entity? Do we know much about it? And the 2022 Banff covers this. When you have not much features of a TCMR and you have microvascular inflammation, what is advised is you look and see, is it above the threshold of 2, score 2, combined score 2, or is it less? If it is more than 2, if either C4D or DSA is positive, no problem. You can straight away call it an AMR. If the threshold is above. If the threshold is met, like in our case, which I have shown you, but C4D is negative, DSA is negative. Earlier, we used to call it no AMR. Now we have this entity called MVI, DSA negative, C4D negative, and I'll tell you what the implications are. You go to the right side where you have G plus PTC less than 2. If C4D is positive, we can call it AMR. If both are negative, there is no AMR. But if DSA is positive, we now have this new category of probable AMR. So that is something that we need to know about. So what does this new category mean? MVI, DSA negative, C4D negative. It's really just a descriptive phenotype. And these are all the conditions which you need to think of when you get that diagnosis. It could be because you missed an HLA DSA and you might want to repeat that. TCMR, when severe, will have inflammation in the PTCs because the inflammatory cells in the interstitium exude out from the capillaries. So the TCMR criteria is something we need to look for. It could rarely be non-HLA antibodies. NK cell activation. A lot is being talked about NK cell as being a key cell in rejection, and that can, when activated, can cause microvascular inflammation. Non-immune causes, non-rejection causes like viral infections like BKV, you need to exclude BKV before we call it TCMR. If you have some suggestion of viral cytopathic changes. And in the early transplant, ischemia reperfusion injury is well known to cause microvascular inflammation. What about, and the general the consensus is the response to antibody-targeted treatment in this group may be low. What about this other category, which we called probable AMR? That is, MVI is low, DSA is positive, and C4D is negative. In this group, people believe that antibody-targeted treatment could be considered. Now, if you will remember the earlier classifications of Banff, in the acute manifestations, acute tubular injury with no other known cause was also mentioned. This is now sort of formally deleted from the criteria, but on and off, we do have this entity C4D with no other features but just tubular injury. Do we call it rejection? So tubular injury is present, C4D is present, but there are no features of either an active or a chronic, either antibody or T-cell mediated rejection. 3 such scenarios this can occur. If it is in the very early post-transplant, first week, second week, in a patient who has been proven cross-match or DSA positive, who has been sensitized, then you could go out and call it as a probable AMR. If it's an ABO-incompatible, we all know that you can get C4D positive. If it is beyond that immediate transplant period and you get only ATI and C4D positive, you cannot call it AMR unless you have a DSA positive as well. So in conclusion, this is a summary of the Banff 22. These are all the entities which are now listed under ABMR. These we know, active, chronic, active. Chronic is when you have the histology, you don't have DSA, you don't have C4D, but you have a prior history of either a DSA positive or a biopsy-proven ABMR. C4D without evidence of rejection is probably accommodation when you have a completely bland biopsy, not even tubular injury, but just C4D, maybe in a sort of protocol biopsy, it's probably a feature of accommodation. This entity I have discussed, MVI, C4D negative, DSA negative, probable ABMR, 2 scenarios, low MVI with DSA positive, or immediate post-transplant prior DSA positive with just acute tubular injury. And C4D with acute tubular injury, the 3 scenarios is what I have described. Just the last few minutes, 2-3 minutes, I would just take to just make you aware of this recent development in the Banff classification, the progression towards looking at activity and chronicity indices, just like we do in our lupus cases. And this was a publication in June this year. And because it is felt that all of you would agree that these rejections are very heterogeneous, you can have combined TCMR, ABMR, and our reports typically do not reflect the full spectrum. For example, you could have chronic active, which could be mild activity and severe chronicity, or the reverse, severe activity and mild chronicity. So these indices have been proposed. It is not a replacement for the category or for the scores, but it is recommended that we could add it as supplementary information, which would be useful to the treating physician. So now what are the activity indices and chronicity indices in the Banff classification as of now? In the tubulo-interstitial compartment, the activity indices, you have inflammation, tubulitis. In the vessels, you have endarteritis, the large vessels, the peritubular capillaritis, and TMA. In the glomerulus, you have glomerulitis, and you have C4D. In the chronicity indices, in the tubulo-interstitial compartment, you have fibrosis, atrophy. In the vascular compartment, you have that CV score, the fibrous intimal thickening, the hyalinosis, and this EM finding of multilayering. In the glomerulus, you have this important transplant glomerulopathy, the double contours, you have the mesangial matrix expansion, and you have global glomerulosclerosis. Now, what these Banff specialists have suggested is you have a formula for activity taking into consideration these 5 indices, which we know are injury patterns in rejections, in acute rejections, namely interstitial inflammation, tubulitis, endarteritis, glomerulitis, and peritubular capillaritis. So these are traditionally scored as 0 to 3, and C4D, if present, is 2, and if absent is 0. So we have a score of 5 into 3, 15 plus 2, 17 as the maximum score, and 0 as the minimum score. If you look at the chronicity indices, the 4 indices which are seen in rejections are interstitial fibrosis, tubular atrophy, fibrous intimal thickening, and the double contours. Double contours was thought as being most important, like, for example, segmental necrosis in lupus, where you double the score. So this is doubled, and these 3 are given the score 0 to 3 as in Banff. So you have 3 into 3, 9, plus 6. 15 is the maximum score, and 0 is the minimum. So now let's go back to our case 1, which was TMA with glomerulitis, peritubular capillaritis, and C4D positivity. If you apply the activity index formula, it will be 2 for glomerulitis, and 2 for glomerulitis, 2 for peritubular capillaritis, and 2 because C4D was positive. So the activity index is 6 by 17. If you look at the chronicity index, all these chronicity scores were negative, so it is 0 by 15. Now we come to this case 2, and these were the scores. If you look at the activity scores, these 5 scores, and you add it up, 2 plus 1, 3, 4, 5, 6 for PTC, and C4D 2. So the activity index is 8 by 17. Chronicity indices were also there. So you add the chronicity index, 2 plus 2, 4. You double the CG score, so 2. So the chronicity index is 6 by 15. This might be more useful to the treating physician, especially when you have these complex rejections and in follow-up biopsies, just like in lupus. You can keep looking at the activity and chronicity index, but really all this needs to be validated. It's all very new and in our subsequent studies. I leave you with some questions which we need to ponder. We cannot divide TCMR and ABMR into watertight compartments because the patterns of injury overlap, and also molecularly, the cellular and humoral immunity is involved in both types of rejection, TCMR and ABMR. That is something we need to constantly keep in mind, and we are constantly understanding more and more about this. Also, as pathologists, we have limitations. What we do in a biopsy is just capture a snapshot of the ongoing process. And this injury process might either decline or might get worse with time, and we have no way of saying that. So that's a great limitation that we have. And we sometimes act like gods. 10 glomeruli in a million, and we try and extrapolate that to the whole kidney. It's something like looking at a horoscope. So that is again a limitation that we have. And besides, we are governed by guidelines. We have the Banff guidelines. So though there are, sometimes you can step out of those guidelines and give really, legally and even otherwise, we need to follow these Banff guidelines when we formulate our report. For example, if you say that there are a lot of plasma cells, should you be giving bortezomib and so on? I don't think there is any enough evidence for that. Neither is there evidence right now to say that we should be doing a subtyping of those cells to say, yes, there are 80% T cells, 20% B cells, 10%, whatever, and so on. Injury patterns overlap and, like I said, may not always be functionally correlated. We might call up the nephrologist and tell you, it looks very bad, there's TMA, there's this, and then you'd only say, no, but the patient is actually doing quite well, he's improving. So really, I think there is no easy solution to this, but the best solution that I could think of was to lie in conversations like this and on a day-to-day basis with our regular cases. And of course, nothing can beat a very diligent clinico-pathologic correlation. So thank you very much for this hearing, and I hand it over back to Purva. Thank you. Can I stop sharing?
Yes.
Thank you, madam. Thank you so much.
Thank you, ma'am, for simplifying ABMR beyond Banff. And ABMR is a dreaded complication which all transplant physicians don't wish to have in their biopsies. Anything else would do, but ABMR. And the issue with ABMR is that I recently have started seeing more cases, but it is
Can you
more
make it a play mode?
continuum.
And it's smaller. Can you make it a play mode?
Sorry, yes.
Yeah, okay.
So it is more of a continuum rather than a one hit. And I believe that once an ABMR, probably, maybe always an ABMR, we don't know yet. But with that, we have our expert panelists, Dr. Arvind sir, Dr. Pratik Das sir, to shed some light on ABMR and whether once an ABMR is always an ABMR or not, or if there is a way to halt the progression of kidney injury. So for the panel discussion, we have Dr. Pratik Das sir from Kolkata and Dr. Arvind sir from Trichy. And I'd like to begin the discussion with the case. It is a case at our center. It's a 28-year-old lady. I'm just one second. Yeah. So it's a 28-year-old lady with native kidney disease of focal segmental glomerulosclerosis. She underwent kidney transplantation in 2023 with her father being the donor. 9 months post-transplant, she developed active ABMR with a rising creatinine of 2.5. So this is her kidney biopsy. I'd like your attention on this red marked image wherein biopsy suggests active tissue injury in the form of glomerulitis and peritubular capillaritis. The features are suspicious for an active ABMR, and a correlation of DSA or SAB is essential. So we got this report, I think, on day 4, if I remember. And this is her DSA. Unfortunately, at that point in time, immediately, we did not have an extended HLA for her father. But then looking at the biopsy image, we went ahead and did plasma exchange initially and then gave rituximab, I think, in the first month. With plasma exchange, the creatinine was 2.5. It didn't improve much, just came down to, I think, 2.3, 2.4. It lingered there for a month. And when she came for subsequent follow-ups, because we were stuck with the injury, we went ahead and also gave IVIG and bortezomib. Somewhere down the line, almost after 2 months of this biopsy, her creatinine was 1.9. On subsequent follow-ups, let's say around, I think, 2 months later, after 1.9, she developed an UTI, and again her creatinine started rising. Now in 2025, from a creatinine of baseline, that creatinine that had reached was 2.3, and at present she is slowly come up to 4 milligrams. We have also done everything to optimize her immunosuppression and also giving supportive therapy like SGLT2 inhibitors and ACRBs for the mild proteinuria also that she keeps having. And repeat DSA is awaited. So my question would be, what would the next steps be? Because I think this scenario must be a common one in our day-to-day practice. So I'd like Pratik Das sir to please address the question. Hello,
Okay.
I think sir's not there.
It's not there?
Yes. Am I audible?
Yeah,
Yes,
yeah.
sir. Yes. Welcome, sir. Welcome.
Yes. Yes, you are audible. Welcome, sir.
Yes, thank you for inviting me. So, this is a patient who developed for 9 months post-transplantations and had an active ABMR, and he was treated, and she was treated properly. Probably, in my case, I would have been given some more plasmapheresis instead of 3, maybe 5 or 6, and there is a partial response to that.
Okay.
So far this active ABMR is concerned in the within first year of post-transplantation, most of the cases, their responses are clinical. There are 3 sorts of responses. The clinical response means a normalization of the creatinine and increase in the urine output. And so this kind of response we usually get in many cases. But there is always been a residual damage if you do the biopsies, if you see the DSA. So there remains the platform for the rejections, maybe an impression for the chronic rejection, impression for the antibody-mediated rejection, or the antibody stays. And if it is so, it also resolves the memory stays. So if once this is ABMR, and if you even treat them, there is always a possibility that he or she will develop a recurrent ABMR, or it may go into chronicity, or may induce an cell-mediated rejection also. So in these cases, so one step we often forget that after treating a successful ABMR, successfully an ABMR, we fail to increase the baseline immunosuppression. That is one important thing, because if you don't increase the baseline immunosuppression, there may be an ongoing rejection or there may be a fresh rejection episode that will develop. So in this scenario, yes, for this, yes, she has responded partially. And after that, we need to follow up. Every time a rebiopsy is not possible, DSA 1 goes up. Here you can see this is a class 2 DSA, and it is not a very easy thing to go. It will stay.
Yes.
Okay, so doing a DSS and repeatedly may not be, this will remain, and doing repeatedly also from economic point of view, it is difficult. So here lies we are performing this cell-free DNAs are helpful, because once, although there is a positive correlation a bit poor, but you know this patient is active, developed ABMR, you have treated, now she is on follow-up. You cannot do a repeated DSA, you cannot do a repeat biopsy every time. So cell-free DNA, if it goes beyond 1%, maybe 2.3, 5.2 or 3.5, like that, it suggests that this active ABMR is going on. So they need a follow-up treatment. Once this follow-up treatment may not be this plasmapheresis, simple IVIG may be a dosage. In a higher dosage in a weekly interval. There are some regimens also recommended. If you give a high dose immunoglobulin IVIG in a weekly manner for such patients, you can just stabilize the renal function and can prevent developing the end-stage kidney disease or a second need for a second transplantations. So for this patient, yes, this is treated properly. Okay, this is nice. Then after that, she needs a follow-up. This follow-up may be in the term of the cell-free DNA, or a rebiopsy also may be helpful. And if it goes and activity remains, then an interval, we give about 1 gram per kg body weight total immunoglobulin and divide it in weekly doses, 3 or 4 or 5 weeks time we give them, and they slightly stabilizes the patients. But otherwise, you have, at the same time, you have to increase the baseline immunosuppression. Otherwise, you cannot say this, it will go on, because it will ultimately destroy the kidney.
Yes. So your thoughts on this, Vail, sir?
Yeah, absolutely. I agree with Dr. Pratik. I think we have done every possible measures. I don't know really the father's age at the time of donation and everything. I think this kind of cases we get at least one case in a month, and we are struck with what next. Probably I think the chronicity has already set in. My aim is to keep the creatinine at this level for another 1 or 2 years and prepare her for second transplant. I think this graft already we have lost. That's what my belief is all about, based on my practice. But in one thing now, the recent times we have started using from others' experience daratumumab. Probably instead of rituximab, I could have gone for a very powerful one. Otherwise, we have done everything. I think this graft might worsen in coming days, and the best strategy is to prepare for a next transplant. That's my take on this case.
Thank you. Thank you so much, sir. We'll go to the next, before we go to the next question. So we have Dr. Neeraja and Dr. Dhanashri madam joining this forum. And the reason why I have come up with this slide is because we usually tend to correlate our biopsies with DSAs and things like that. But the tricky the tricky DSAs are the ones between 1,000 to 3,000 MFI and the 3,000 to 5,000 MFIs. In these scenarios, even if we consider doing a lot for the patient, that can push the patient to over immunosuppression and infections. And if we underdose them with immunosuppression, of course, they may continue to have rejection episodes. So I would like Dr. Dhanashri and Dr. Neeraja ma'am to comment on scenarios in which can we somehow have investigations like C1q, which is a little difficult to get in India? Have these assays helped in diagnosing cases before the biopsy is done?
One more thing, what you can do is C3D assay.
Yeah.
You can perform C3D along with your DSA SAB, and of course, if you have whole background of HLA typing, one more thing you can do is epitope matching ahead of time when you select the patient and donor. So if applet score is high, then you are aware of that patient might need higher immunosuppression dose. That you can do as a precautionary step.
Right. So this question is about.
Yeah, I just wanted to add a
Yes.
few more points, Dr. Purva, that when the MFI is between 1,000 to 3,000, the only best way to treat the patient is through plasma exchange, because in our experience, what we have seen is patients who have DSA with an MFI of 1,000 or 3,000, the DSAs generally go with 4 or 5 cycles of plasma exchange. And if the MFI is above 5,000, it is always better to, as Dr. Vale has suggested, to go for the second transplant, or if it is in the initial stages or pre-transplant workup, it is always better to change the donor, because the risk is very high if the MFI is above 5,000. So between 1,000 to 5,000, you can manage the patients with the plasma exchange. And as Dr. Dhanashri has said, as in your case with that girl, what I have seen, the HLA typing was done with a low resolution, right?
Yes.
So you have to go always for a higher resolution or, intermediate resolution HLA typing, and
Yes.
then see whether and all the donor antibodies are they represented in the single antigen bead assay, what we have done. And
Yeah.
epitope matching, as Dr. Dhanashri has said, it is the best option, and you have to see in which epitope does it fit and what is the MFI. So 1,000 to 4,000 is manageable with the plasma exchange, but above 5,000, it is always better to redo the single antigen bead every 3 months to manage the patients, like if there is no other alternative with the donors.
Right.
That's what
Actually, with single antigen bead, the problem is that it may not always give a donor specific antibody. I mean, we have to match it with the HLA report, right? So we want to know, or what this dilemma which we have is whether we have any technology wherein the donor specific antibodies only, like what was there in the HLA report, only those antigens can be tested.
No, there is no such option. As such, we cannot do testing for only those donor-specific antibodies, because the single antigen bead test, what we are doing is a panel. And each bead is representative of one single antigen, and the reaction mix, what we get is a mixture of the panel. So we cannot do single antigen or single antibody testing as such. As you have said, suppose like in the HLA typing of the donor, suppose A0101 is there, we cannot directly test only for the presence of grade 1 antibodies as such, since the kits whatever available is only of a panel. But if you want to reduce the costing and all, as in your case, we can just repeat the panel of either class 1 or class 2, whichever is positive. And the typing of the donor also, only that particular locus also we can test it, just to reduce the cost. That is
Right.
the only option.
Right. I'm sorry to interrupt. I think there's a lot of noise from, can we mute that? Thank you. So coming to the next question to Pratik Das sir. Sir, what is your approach when you see a renal allograft dysfunction with C4d negativity, normal TAC level, no DSA with thrombotic microangiopathy?
You can see this is a biopsy of graft dysfunction, and there is TAC level is normal, C4d is negative, and there is no comment on whether there is any evidence of inflammation as Swarnalata madam was taking. This is very important, maybe a microvascular inflammation or maybe an overt inflammation that suggests an associated antibody-mediated rejection. If we take the question, the C4d negativity and a normal DSA, and if there is even on the biopsy, there is no evidence of microvascular inflammation, then probably this is not related to the antibody-mediated rejection. This may be an TMA that may happen due to so many causes. If you take those causes other than the rejection, it may be a drug-related. Drug information is not there, but we know there are so many drugs in the transplantation, mostly led by the CNIs, and as maybe ATT, maybe everolimus, they can precipitate this TMA. And also this can be a recurrence of there is no information regarding the native disease. It can be a recurrence of the TMA that may be complement mediated or the atypical HUS that has been recurred. So for approaching to such patients, when you get an TMA, we should look for whether the peripheral evidences of the thrombotic microangiopathy like low platelet or the anemia and the hemolysis, these are present or not, because these are important for doing a biopsy in such patients. The biopsy has been done in this patient, and probably the peripheral things are not there. Still, it can be related to the CNIs, because CNIs precipitate the TMA not only by a dose-dependent manner, it is an idiosyncratic reaction in many cases. So even a small dosage of the tacrolimus can precipitate the TMA, and you cannot reverse it until and unless you completely withdraw the TAC in the post-transplantation period, and that will be a very difficult decision to make. But sometimes if we get, yes, there is you are sure that is a TMA may be the important cause, and other things you have excluded, you can withdraw and you can replace it with the other drugs with the option that everolimus also or can also precipitate the TMA. And at the same time, because you know this plasmapheresis and anything, plasmapheresis, this thing can revert the extrarenal manifestations of the TMA, but cannot revert this renal manifestations or renal dysfunction if it is related to the drug. For that, you need to withdraw the drug. Secondly, it can be a recurrence of the typical HUS that was probably present. Nowadays, you should be very cautious about that, because you should take if the TMA biopsy is there in the pre-transplant period as a native kidney disease, that is fine. But this is not always present. In that cases, we have to look whether the patient is a postpartum AKI, whether it was associated with the multiple platelet transfusions in the initial period, whether there is a strong family history, other members have suffered from similar kind of disease, whether the pre-transplant recurrent accelerated hypertension and hospitalization. This suggests probably atypical HUS may be a possibility. Now, if these things occur, nowadays we have the options, and the drug is now available in India. So in those situations, we can send the patient for the genetic testing, but this takes some time. But we can start, this is eculizumab first. This is another approach. This may not be economically viable in our cases, but for the sake of discussion, this is for the TMA. If you're not sure what is what, and we don't have the genetic study, even this, then there is a study, you know, the eculizumab first. That is published in 2023 in Kidney International in 45 patients. Amongst those, around 15 patients didn't have the genetic HUS, but still they responded to this complement inhibitors. So if the TMA is there, for us, we have to look for the causes. If it is a minimal suspicion, it can be a recurrence. we can go ahead, we can start always plasmapheresis, but if the drug is available, if the patient can afford, and if it is available in a reimbursement manner in a government situation, now it is in the very rare disease list, so we can go through the government medical colleges and get it free also. So we can start the treatment as early as possible so that we can get a response. But at the same time, if the things goes worsening, you can do a repeat biopsy. As madam was telling, the repeat biopsy, the inflammation may develop. People may very early period may not be there is inflammation. Inflammation, tubular capillarity, glomerularity, those things can happen in subsequently, and it can be simple ABMR and the treatment pattern slightly different with the addition of the immunoglobulin, addition of the rituximab, plus minus bortezomib, whatever may be. So TMA, if it is drug related, if once you are very sure, then only withdraw the CNI. You should be very cautious. It is a recurrence or not. There should be nowadays, we should have eculizumab first approach, at least if it is possible. And if there's a rebiopsy, is always helpful to get it, then it can be ABMR, a different kind of treatment.
So the second question is, how can we diagnose ABMR at the earliest, especially with an ABO-incompatible transplant? I think some 1 year back had reached out to you for
so
a patient.
this is ABMR in the post-transplantation, in ABO-incompatible transplantation is a
Yes.
slightly different scenario.
Yes.
Because you know, there's a three kind of dilemma that can develop. ABO-incompatible, you have done with an acceptable titer in the post-transplant period, titer going up. From a 32, it goes up to 256, maybe 500, maybe 1000, so that we should react or not. So it is already established nowadays, if there should not be a knee-jerk reaction to do an plasmapheresis or any kind of intervention until and unless there is a graft dysfunction. Because you know, the ABO antibodies, those are not very much unlike the some HLA antibodies. ABO antibodies are not that harmful, and they per se sometimes may not cause any damage. If ABMR happens in ABO-incompatible transplantation, if there is a failure of accommodation. So if the accommodation fails, then there is development to the ABMR, because you can get 2000 titer, do the desensitization, do the transplantation. After that, it goes up. Still, there may not be any ABM. So first scenario is that monitoring of the titer only should not be a point of reaction. Secondly, the surveillance biopsy in sensitized patients in HLA antibody cases, we do the surveillance of protocol biopsies. This is not very much helpful in ABO-incompatible. Why? Because of two reasons. You get, as madam was telling, you can get an evidence, you can get a C4D positivity without any evidence of inflammation. And it is usually in the slightly lower tune, and it is widely distributed, not in the targeted zone, not in the peritubular capillaries, not in the glomerulus, but in everywhere, even in the tubular basement membrane, you can get a C4D positivity. So that cannot give you a diagnosis of the ABMR. And secondly, if it is all never be a subclinical one, because it is not related to the antibody. It is a failure of accommodation. If your accommodation fails, it is a catastrophic ABMR. So it will never be a mild, slight, this is a very significant and severe type of ABMR. You have to, if there is an antibody goes up and you have graft dysfunctions, and you are thinking seriously that is an antibody-mediated rejection, do a biopsy, getting inflammation, you have to act very rapidly with aggressive plasmapheresis and giving the donor's plasma frequently, and after that IVIGs, and in many cases we lose the graft in those situations. So ABMR is, yes, the titer. One is a C4D positivity, third is a surveillance biopsy, and it's a severe ABMR that has to be kept in mind for ABMR.
Right.
And also one point I want to make that it is not that the HLA related antibody mediated injection doesn't happen.
Sorry, sir. 1 second. Yeah. Yes, sir. Sorry, sir.
HLA mediated antibody mediated rejection, other than anti-HLA antibody mediated, that also happens in ABO patients. ACR can happen in ABO patients. So if you think of this is the antibody mediated rejection, you have to do a biopsy, and at the same time you cannot ignore by doing a DSA. You have to do a DSA again. It may not be ABO related, it totally HLA related antibody mediated rejection. In those situations, you have to treat it accordingly. And you should be just cautious that yes, patient's plasma should not be given in the, it should be donor's plasma or maybe an AB plasma that can be given.
Right. So why I've got this question is because we had a pediatric patient for whom we had done ABO-incompatible transplant, and On day 4, he developed graft tenderness. We got a biopsy done. It was ABMR. And surprisingly, again, as Sir mentioned, the titers were going up. But there was no other evidence. The DSAs were negative. Everything else was negative. And we lost the graft in, say, 3 months.
Yes.
And we should back on maintenance hemodialysis.
If you take our experience, it is the lower titer. Maybe you have 16, maybe you have the 16 titer, 8 titer, 4 titer. You have done minimal desensitization and doing the transplantation, and then there is a massive ABM.
Yes.
So 2 questions in my mind. Yes, whether there is a prozone phenomena does exist for an ABO antibody also. You are getting a 2 titer and without desensitization doing the transplantation, and after that you get maybe a 512 titer in the post-transplantation. That is one important thing. And second thing is desensitization is always good because it doesn't only remove the antibody, it removes the complements, the bigger molecules, and the whole inflammatory milieu is removed. That is makes the platform they don't develop antibody mediated rejection even in a low titer.
Right. Actually, what the lesson learned was we were told that you do 3 or 4 consecutive days after you achieve the least titer before you go ahead for transplant. If there's no rebound, then go ahead for transplantation. Because the titer which we went for during transplantation was, I think, 1:1, 1:16, if I'm not wrong. And second thing was we did almost 3 to 4 sessions of immunoadsorption followed by plasma exchange also, but then there was no recovery. Now, coming to the next aspect, that is C1q C3D assay. It is an assay in which C1q reflects can the antibody start the fight in layman terms, and C3D is how far did the fight go between the antigen antibody complex in the kidney. And of course, C4D is the fight really happening? Is what it reflects on kidney biopsy. But we want to probably act, especially when the fight actually starts. We want to act before that to give a better graft outcome. So Dr. Shruti ma'am couldn't join us, but she gave her set of additional tests for evaluation for ABMR. Probably you can just pause the video and see the slides later on. Coming to Arvind sir, thank you for patiently being there. Sir, since you have been very actively sharing your Doppler findings on the peculiar group, the first question is, what are your observations to correlate ABMR with Doppler findings?
Thanks, Purva. See, my boss used to tell HL3 is no more right now. All transplant undergo rejection all times. That was the famous word he always uses. So let's come to the in a setup of a transplant, rejection happens in odd hours, right? If you do a transplant in your center, if you do routine in the late hours, you will get problem even within 3 or 4 hours. So probably doing a biopsy. If Sunday falls between your Saturday and Monday, then the problem of sending sample, all these things until otherwise you have an in-house.
Right.
Yeah. So with this, I'll make a very brief comment on this. I'm a high proponent of Doppler advocacy, advocating. I mean, utilizing the Doppler on finding a acute ABMR, active ABMR, as well as any kind of changes in the graft, which can be reflected in Doppler findings in a very clear. That's why I promote it as a biomarker. Ultrasound as a biomarker, because ultimately reflects vascular flow, velocity. Whatever it happens to the lumen of the vessel will reflect it through the velocity. Then ultimately we understand the velocity of the vessels. Then you can understand what is happening inside. Kidney is a small organ, so you can identify from the main artery to the interlobar artery to the arcuate interlobular. So till this interlobar artery and arcuate, if you put your Doppler is very sensitive, you can make a lot of diagnosis. That's the reason wherever center I go, I insist one Doppler machine should be inside the post-transplant room. All the staff who's attending the cases should know how to do a basic ultrasound on any given transplant patients. So here, see, in any resistance, if you do a Doppler, ultimately whatever the reflection is, any downstream resistance will be reflected on Doppler finding. in a case like just today's topic on acute ABMR, so we just see what will you see? So for example, patient is making to 600 ml output, suddenly 200, then anuria. See, only two things can happen. It could be a hyperacute rejection, the little late hyperacute rejection, or some kind of arterial thrombosis. If surgical team is good and you are confident on a surgery, then your conclusion is only on immunological issues. So the first you see ultrasound, basically you cannot see any, if a 1 day old, 2 day old kidneys are maybe showing some kind of a corticomedullary effacement, a CMD will be slightly hazy. Otherwise, it will be well differentiated. You cannot differentiate within 10 hours of post-transplant. You cannot differentiate between, rejecting kidney and normal. It looks very absolutely normal. If you do a power Doppler imaging, it will be less intense. If a patient has already have a glomerular antibody-mediated rejection, the power Doppler will be like an arborization. Every beat, the pole to pole, you will get a complete filling of the kidney. Because the kidney is superficially placed, if you have a 4 or 5 megahertz curvilinear, it will show the entire kidney pole to pole. You will have arborization of a blood flow. That will not be there in ABMR. This is the first sign there will be a little flickering. So you know that even if a person gets a penicillin allergy, if you do a second dose, you'll develop within seconds. He develops allergy, right, and anaphylaxis. Like the immunological reaction is robust actually. The last hour will be 400 ml. Next hour will be anuria. So this kind of a robust phenomenon we see in our patients. So immunology and the surveillance inside the system is so quick. It will so our understanding about this also should be quick, and response should also be quick. So this is the first thing, power Doppler. Second is a color flow Doppler. If you do a color flow Doppler, most of the time got Purva, can you make it a little?
Sorry. Just
okay.
Glitch from my end.
No noises. So okay. If so people might say that, sir, I put a color Doppler, everything surgical issues were not there. It was a clinical finish. When as soon as I shifted the patient to the post-transplant room, after 3 hours, I see only the hilar or little the medullary flow. That afterwards there is no flow. So flow up to medulla will be appreciable, not afterwards. I mean beyond that. And next comes the most important thing is a spectral pattern. So these are the 4 things we do on ultrasound. So you see, in a main artery, it become a hilar artery, and the hilar artery become afferent arteriole. If there is any flow obstruction in the afferent arteriole, there will be a dampened systolic spike. Okay, that's not a routine case in any antibody-mediated rejection. It goes to the glomeruli, or after the glomeruli, you have a efferent arteriole, then peritubular capillaries. So there are a lot of, when I was learning this ultrasound skill, especially renal Doppler, in a post-transplant antibody-mediated rejection, sometimes I see patients in the 7th, 8th day, they go home with the 1.4 creatinine, then come again with the 2, but absolutely the patient will be normal. Only creatinine elevation will be there. There's a mild relative drop in urine output. Graph looks normal. If you put a color Doppler, all this systolic, diastolic, continuous flow will be there. But you do a biopsy, the report will come as an antibody-mediated rejection. What we find in the last 7 to 10 years, where my understanding about the renal Doppler has become more clear, see, probably those kind of patients is amenable to treatment. Even sometimes I don't admit the patient, just ask them to come after biopsy, do on just pulse them with methylprednisolone because their output is good, graft flow is good. Probably they're just ABMR setting in. This is all happening in a no DSA setting, no there were no predictive risk like DSA were normal, no transfusions, all this kind of thing. We ruled out everything. There's a clear-cut case. If I feel that there must be just antibody-mediated rejection just setting in, probably the antibody interaction with the endothelium is not happening at the glomerulus level. It is not efferent artery. It is in the peritubular capillary level. So that is where the downstream resistance will not reflect on Doppler finding. Doppler will be absolutely normal. So this is the one thing I learned over the years. So if these kind of people, even my threshold for biopsy will be low, then I'll do a biopsy because I just want to have correlation. In these kind of people, PTCitis with a no or minimal glomerulitis, probably there will be no cutoff, or there will be diastolic cutoff will be there, no reversal will be there, and there is no graft tenderness. There is no medullary pyramid echoes will be normal, and the pole-to-pole length of the kidney. See, that's the reason soon after the transplant, you have to measure the pole-to-pole and transfer the length so that you can understand later what are things happening. Even small increase in interstitial edema and pole-to-pole increase in length will give a clue, along with patient graft site pain, all this will give a clue that the rejection is going on. So this is the entire nutshell about this approach. In the wide spread of obstruction, the countless glomeruli throughout the kidney create a state of downstream vascular resistance ABMR. So if it happens in glomerulonephritis, for example, PTC2 grade more than 2 and G more than 3, probably the entire glomerule is gone. So probably your resistance is very high, then you will get a only systolic spike. If you get a systolic spike in any patient with a clinically you're suspecting this could be because your mind reading is the first diagnostic clue. You know, you are given a patient, you know that this patient is likely to develop a antibody rejection. It's not happening every patient. So out of 10 patients, you have a predetermined approach that this patient might go in for a problem. So those kind of patients, if you put your intuitive intelligence and your Doppler findings based on your predictive risk, what you had in your hand, and then your diagnosis of ABMR on ultrasound will be perfect. So this is what I rely. Without it, I just take a biopsy because the report will come after 8 hours, 10 hours, 12 hours sort of thing. Then I'll just start the treatment. If you have a very narrow systolic spike, as the base become narrower, the spike become, that is called, I call it as a doubling. Next one. Yeah, thanks. So I think I see. So here, suppose you have a stump flow. This is a very, very essential pattern. I just want whoever watches this, please remember this pattern. If you have this kind of pattern, for example, if you do a transplant on a highly sensitized patient after desensitization, anything, or ABO patient that tighter spikes, fourfold afterwards, you think that strongly this patient has developed antibody-mediated rejection, especially ABO-incompatible, DSA high, or very high Craig positive patient, especially epileptic mismatch more than 30 in DQ especially, and severe reperfusion injury in a long cold ischemia hours in cadaver. You do a transplant, you shift the patient, everything's all right, then do ultrasound. Soon after the anastomosis, I'll always document inside the theater with the unsuspected patients. I just record it, then shift the patient, then you see this kind of pattern. This is called stump flow pattern. This is called pre-occlusive thump. Actually, the otherwise known as pre, because this is noted in carotid artery. Because this is actually radiologist and neurophysician doing in a carotid artery. If you do ultrasound the carotid artery, the complete occlusion, it's like a water hammer pulse. The blood will pushes inside the artery, then comes back. This is called stump flow pattern. If I see this finding, then immediately I just back of the mind ask the patient, staff to prepare for plasmapheresis and other things. I prepare my mind. If it persists more than 12 hours and 24 hours, I give up everything. I've lost the battle. Because after 25 years of my practice, I don't want to give too many immunosuppressions, and victory comes at the cost of devastating cost to the victor. What I do with all bortezomib IV or daratumumab recently, and ATG repeat ATG dose, plasmapheresis, and make them patient poor, and I make them lifelong trauma to the patient. I just give up my approach and do a nephrectomy. Most of the time, I'll go and see the inside the graft will be dusky, swollen, about to rupture. So these are my many cases the last 24 years I've found. So I need not over-treat the patient. So at least if I see this finding, I'll institute a therapy. If I don't see a response, I'll give up everything. I prepare my mind. I prepare the patient for the next, at least I'd save money for the lifelong good dialysis. So this is what my approach. If you see a stump flow pattern, 95% of the time it is ABMR. It is ABMR, and it's a 99% it is a. With this I finish, and next slide is one slide is a very crucial slide. Go to Purva, next one.
Yeah.
Okay, this is the spectral pattern. I call it as it's my approach. Probably if you be with me for some time, you'll understand what I'm trying to say to the world, that how the Doppler can be a good biological marker. See, there are three kind of things in a Doppler. I'm talking about a patient with a sudden drop in output in a suspected. If your predictive risks were high on particular patient, you suspect this patient could develop a ABMR. So this, if you do a spectral pattern, the three approaches. If I see a normal Nandi pattern, Nandi is the joy. Actually, Nandi in Sanskrit is meaning of joy. It's a systolic, broad systolic base, and diastolic will be continuous, like this pattern. If I see, I'm so happy. If it is ABMR, it may be my assumption is this kind of people will be having PTC more than 1 or 2, but there'll be a G1 or less than G1, or probably near normal urine output they'll be having. The only clinical sign I may be having is a creatinine elevation, or creatinine may not come down as we expect in that kind of patient. So this is a still there'll be a normal Nandi, but still I have suspicion, then I'll go for biopsy. I will institute therapy, but I'll do it in a relaxed way. But you come to the middle one. It's a broken tower pattern. It's like, pattern which has got a narrow base, not a much narrow. It's a slightly narrower than not broader, not narrower. It's in between that. If you have that kind of a spectral pattern with a reversal, it could happen in a severe ATN, or it could happen as ABMR also. If it is a reversal, my approach will be different. If it is without reversal, then I'm just think about whether this patient had any kind of insult inside the theater, or predictive risks were high before transplant. All these things I'll take into account. I'll act a little, slowly. So most of these patients will be having ATN because prolonged lap nephrectomy, prolonged ischemia. Our patient might be having long cold ischemia in the cadaver transplant. So my approach will be different. But here downline, you can see the venous flow also continuous. Please never look at in a critical care, we look at not only SpO2, we look at ETCO2. So likewise, in the vein flow also very important. If you have a good follow and forward flow, and the venous pattern also look very nice, the nice spasticity is present with the respiratory cycle, then venous flow is good. Even I'm just comfortable that this patient might be having mild TCMR, or could be a mild ATN, this might recover. But if it's a reversal, my approach will be different. So quick and aggressive. Then come to the left corner. It's a stump flow pattern. If it's a stump flow, mostly these kind of patients will be extensive TMA, part of ABMR, maybe having G2, PTC more than 3. And this patient, as ma'am said, as Swarnalata ma'am said, it could be present TCMR as well as ABMR, V3. This patient will be having transmural intimal, starting with intimal to that whole vessel will be involved, maybe having fibroid necrosis. This patient will be anuric, will be muddy urine. See, any patients who develop having a good urine output, sudden drop in urine output with like a hematuria, then will become muddy. Most probably these patients are having acute ABMR, active ABMR. You are dealing with a point of no return. So you have to start quick your therapy, initiating plasmapheresis, other things. So this patient might be having low platelet somewhere. But if you do an initial biopsy, they'll be having only severe ATN. If you do 6 hours later, you do a TMA. The another 6 hours, you do a complete picture of IBMR will be there. So stump flow pattern indicates poor prognosis. And if you wait for a few days, cortical necrosis, likely to happen in the next few hours, then extreme fast and aggressive, at least you institute a therapy or remove the graft. Earlier, the better. So this is the very practical approach one can have. If you start using ultrasound day-to-day basis in your every patient, good, bad, worse patients, you will come to know how helpful it is to diagnose your vascular phenomenon through just a simple external device called ultrasound. So rather than instead of instituting too many therapy on a patient, this is called stump flow pattern. This is basically, it's a pattern seen in a carotid artery, complete occlusion. It's like a water hammer, just back and forth, rapid upstroke, rapid downstroke. Sometimes you get reversal also. So inside the vessel, your flow. So in a ABMR, your afferent arteriole glomerulus will act like a one conduit where the column of the blood is not moving. So it's like a stump flow pattern. It's been never described in any textbook. The last 10 to 15 years, last 5 years, I've been promoting this concept everywhere. And across some institution, I get a call back, said exactly what you say. I reflect on the findings as well as on the post-transplant, nephrectomy findings. So please take this message as a lesson and you can validate on your own. This is my message from the answer to your first question, Purva.
Thank you so much. Actually, if you get to practice this often, it will be like a nephrologist's biopsy, not like the poor man's biopsy is urine. Similarly, for us, it will be doing a Doppler immediately bedside post-transplant.
A short learning curve. It's not a big learning curve.
Yes. So honestly, we will not have much time to discuss this, but I'd like you to quickly give an answer.
I'll give the second answer. I read it already. I call it everyone called it a mixed acute rejection. It's a two arms of adaptive immunity striking you at one time. Most of the time, most of the times, ma'am said there is no like a TCMR ABMR. It's like a one unit. It will like interconnectivity. So that's madam has given last slide beautiful all description about pathologist mind and the clinical pathological correlation, very important. But here is the one building got fire at two end. So which end you have to pay attention? This is what is the thing. The strategy is not choose one treatment. You have to choose and combine the both treatment. But it all depends on the clinical context. I cannot say say everyone has got different approach. But most of the time, TCMR patient, if I don't see G involvement or CD4 negative vessel involvement, most probably PTC might be a part of TCMR. That's why my conclusion is all about. I'll see the urine output, patients in a cytokine release phenomenon like a paralytic ileus, patient's appetite, or in a fall in hemoglobin, like some kind of platelet count, and a peripheral smear not showing any kind of a microhemolysis. All these things I'll take into account. I treat which arm is more of adaptive power. And then if it is severe, then I will combine both. Very rarely I'll go with the ATG again. And this arm I'll go with the plasmapheresis with rituximab. And bortezomib, daratumab, I'm not very convinced recent times. I'm just convinced with IVIG and rituximab and plasmapheresis for ABMR. And this side I'll use methylpenicillin first 500 milligram for 3 days, not 1 gram. Then I'll go with the ATG if it's not responding. But it's all clinical. Every patient is different. And as and the response may be different. Whatever we see on a clinical and histopathological may not be true with the clinical correlation. I think individual attention is very important on particular case. Thank you for.
Thank you, sir. We will not be able to discuss this much, but I have a few points that I would want probably, we discuss it in our later lectures. So we already discussed is first episode of active ABMR ever reversible. Sir has already answered that very beautifully. The only problem that happens is when the creatinine starts creeping, there's whether we should just continue giving plasma exchanges, and when do we stop and say that this is it, now we can't do much, just go ahead and consider for second transplant. I would like Pratik Das sir's opinion on this. So when do we stop plasma exchange? When do we declare that, we cannot go further?
No, actually, if you are treating within first year of post-transplant and you are getting an active ABMR, there is antibodies positive, you plan for plasmapheresis, then you can give up, as per recommendation, give a 6 sessions of plasmapheresis. If it doesn't respond in 6 sessions, there is no point of continuing it or repeating it. So far plasmapheresis is concerned. For that reason, you have to consider for other lines of the therapy. But one thing is important as that we should not over immunosuppress, because life is more precious than the kidney. You have to timely take down their immunosuppressions, because over immunosuppression is definitely a genuine problem for the ABMR and the treatment patients.
Right. So just before we close this discussion, ma'am, I'd like your opinion about the IHC staining of renal graft biopsy tissue with different CD stains. Is it possible that we may see these stains in the future, which will guide us in choosing immunosuppression?
Yes, Purva. Of late, we have been receiving requests when we diagnose rejection to tell us, are there T cells, are there B cells, are there plasma cells with those respective stains. I have done it for a few, but I think that's a very, very simplistic view. Surely, our immune cells don't work in compartments, and there's much more to these immunologic processes than we understand. So while I'm doing it and I'm sort of telephonically telling them, I don't put it down on paper, but I don't know whether there is enough evidence right now to give a number to these cells, especially when the nephrologist is going to base the treatment based on what you give them. I'm quite skeptical at the moment, but I stand corrected. I'm willing to see how things develop and offer this service if I think there is some value to it. Yeah.
Right. So I think we look at this part of the biopsy as like there's a lot of people involved in national security. Like there's police, there's spies, there's a lot of cadres of people trying to protect the country. Similarly, we have a lot of cells trying to protect the kidney at the same time. So like ma'am already said that everybody may not work in compartments, but nevertheless this is a slide which suggests the cells and what treatments have been given so far, and these are the references to that if anybody wants to read them. One question was about plasma cells, which we had discussed prior to starting this session. We all know that plasma cells, if they are there found in the biopsy of a transplant patient, they're difficult to treat, and we offer them bortezomib and steroids and IVIG. But there is not like, it's not a black and white final treatment for these cases because they are difficult to treat. So I think ma'am's this statement that, we are yet to evolve, if we get more answers on this part, it would be helpful for clinicians. So with that, we can conclude this session. I know there's a lot of questions coming in, but I won't be able to take them up because of the time. But to conclude, we manage ABMR as of 2025 with this care approach, wherein we either reduce the circulating antibodies, then we neutralize them, suppress the new antibody production. And these are the treatment lines, or these are the medicines that we are using. And we are still waiting to improvise because these are not always perfect when we are treating in life. So thank you so much for attending this session. And I wish everybody a very happy Independence Day. And since we are going to continue this Banff session next month also, I look forward to everybody's attending on the 5th of September. Thank you so much.
Thank you.
Yeah.
Thank you, madam.
Thank
Thank you.
Thank
Thank
you.
you.
Thank you.
Dr. Arvind. And good night, everyone.
Thank you for a
Yeah.
wonderful session,
Good night.
Sir
Yeah.
Pratik,
Thank
sir,
you very much.
ma'am. Thank
Thank
you.
you,
And a
Purva.
special thanks to Neeraja ma'am and Dhanashri ma'am, because they came in last minute, and we still haven't done justice to discuss with them. But I think in the future we will definitely have.
Yeah, I thought Dhanashri ma'am would talk about C1Q because we have started doing
Yeah.
with her now.
Yes. Yes.
Thank you.
I hope we can
Thank you.
drop the
We
name
also
of
enjoyed.
So
Thanks for good
Good
night.
night, everyone.
Thank you, Purva.
Very
Thank
good
you,
night.
sir. Thank you.
Thank you, Purva.
yes.